Welcome back to the Doctor is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California, with Pebble Beach and Carmel, Carmel by the sea, Carmel by the point, and Pacific Grove. I'm delighted you could join me for this next segment. What I'd like to discuss is the all-important decision-making progress when planning your breast augmentation. First of all, one of the most common requests that we receive as plastic surgeons, certainly in my office, and I think that's true nationwide and probably worldwide, is when a woman comes in who wants her breast to be bigger, fuller, rounder, and sometimes higher. I hear oftentimes that a woman will say, all my sisters and my mom had big, full, round breasts. I have small breasts. Sometimes women come in and they say, I really liked being engorged when I breastfed, and now that the child breastfeeding is completed, I feel like I've been deflated and my breasts are kind of loose. I think those are two of the most common scenarios that I hear, two of the most common requests that I hear. So in summary, there are two major ways that we do breast augmentation in this country. Very briefly, the first way is sometimes called the natural way of breast augmentation. That's with a woman's use of a woman's own fat. What that involves is liposuction, say of the arms and the tummy, sometimes the waist and flank, sometimes the thighs, outer thighs, inner thighs, wherever a woman feels like she maybe have too much excess fat. And instead of discarding that fat like we do with typical liposuction, we concentrate the fat. We sometimes centrifuge it, we can spin it down, we can decant it, remove that excess fluid that doesn't help, and those concentrated fat cells we can graft. We can graft those to the breasts, we can graft those to the buttocks. You've probably heard of the Brazilian butt lift. We can graft those fat cells to the chin or to the cheekbones. We can help to restore the volume loss of the face that occurs with time. We can graft those fat cells to the back of the hands. So the so-called natural way of breast augmentation, fat grafting, can be done. I would say in general, you can expect a modest improvement in the size of the breast, as opposed to when we do breast implants, you can have a modest improvement if you'd like, but I think that to get a large breast augmentation is probably more straightforward, probably more dependable and reliable with implants, which is the second most, or I should say that's the second commonly offered way of breast augmentation. That's breast implants. So there's a use of a woman's own fat, and there's the use of breast implants, both resulting in an augmentation. So what are some of the decisions to be made when planning out your breast augmentation? First of all, there are 4 different incisions that can be made. Most commonly, and in my practice, most commonly, there's the inframammary fold incision. That's a short incision between 4 and 5 centimeters in length in the fold underneath the breast. There's also the axillary approach. That's when an incision is made in the armpit or right at the junction of the pectoralis muscle and the axilla or armpit, and then that way we can dissect under the breast tissue, or we can dissect under the pectoralis muscle, and we can insert a breast implant that way. I would say that's a certainly less common approach for breast augmentation, probably because studies indicate that asymmetries can be more common with that approach. But for certain women, that can be a good approach. The other, less commonly used, is around the areola. That the nipple is the projecting part, of course, that's the nipple that projects, and surrounding the nipple, that's the tan part, that's the areola. So the nipple areola complex is at that center portion of the breast. So there are different incisions around the nipple and areola. One of the incisions that I sometimes make is a curvilinear infraperiareolar incision. That's a curvilinear incision right where the tan part of the areola changes to the more pale skin of the breast. We can use that incision to gain access. If a woman is going to have a breast lift and we make that periareolar incision, Oftentimes we'll make a vertical incision, and that leaves kind of a lollipop scar or a tennis racket scar, the tennis racket incision. Oftentimes, through one of those incisions, or through part of those incisions, we can also insert an implant to do an augmentation mastopexy, which not only makes the breast bigger and fuller and rounder, but it also elevates the breast gland and nipple areola complex. The fourth way that we can gain access to the breast tissue is probably the least commonly used approach in this country, and that's the transumbilical breast augmentation. In other words, going through the belly button. Or if a woman is going to have a tummy tuck at the same time that we do a breast augmentation, we can keep on going with our undermining or loosening up the skin of the belly, and we can go all the way up to the breasts and insert the breast implants that way. I would say the so-called transumbilical breast augmentation is the least common way we do breast augmentation. One of the reasons is because a saline implant comes empty and it has to be rolled up and placed into a metal tube like a cigar. And the manufacturer is concerned that that's going to be sort of hazardous to the breast implant. It can be punctured, it can be torn, and oftentimes the warranty is sort of voided if we do that approach. So again, in summary, the most common approaches are inframemory fold incision, I think followed by the armpit incision, followed by some variation of a periareolar incision, followed by certainly the less common approach is the transumbilical approach. So those are decisions. That's one decision to be made. Now, the next decision to be made is where to put the breast implant, above the pectoralis muscle or under the pectoralis muscle. That can be a somewhat complicated decision to make that I like to help my patients make. In general, the rule of thumb, so to speak, we use something called a soft tissue pinch test. We need about 2 centimeters being able to be pinched between the thumb and index finger of tissue overlying an implant to properly sort of disguise the implant, shield the implant, minimize the effect of, say, rippling and ripples. So if a woman has at least 2 centimeters of skin and subcutaneous fat and breast gland, then in general, it's an okay idea or satisfactory to put a breast implant under the breast tissue itself. In other words, above the pectoralis muscle, but under the breast tissue itself. If a woman has thinner than 2 centimeters in the soft tissue pinch test, almost always we will recommend that we will go under the muscle. In other words, regardless of whatever incision we choose, we can elevate the breast tissue off the pectoralis muscle to insert an implant, or we can elevate the muscle, the pectoralis muscle, off the ribs and put the breast implant in that way. That's called a submuscular pocket. There's also some variations, dual plane. This morning I did a dual plane approach where I loosened up or disconnected the overlying breast tissue, breast parenchyma from the pectoralis muscle just for a few centimeters up to the nipple areola complex. And then I didn't keep on going, but I backed up and then I went under the pectoralis muscle to create the pocket. I put the implants in under the pectoralis muscle, and what that allowed, that undermining or separation of the breast gland from the pectoralis muscle, what allowed is for that breast gland and nipple to be elevated slightly. And so what that did was correct some ptosis or droopy nipple areola complex, some droopy breast, without making an incision on the outside of the breast. So that helps with that. It allows us to mobilize to a much more attractive position the nipple areola complex. So there are certainly pros and cons to going under the muscle or above the muscle. I can give you a general rule. Saline implants in general go under the muscle. Silicone implants can go above the muscle or under the muscle, above or under. And that's something that we need to discuss based on your desires, based on your size. Your soft tissue pinch test is going to be key. The position of your nipple areola complex, whether or not you have some ptosis. In general, if we put an implant underneath the breast tissue, you'll get a little more lift than you will get if we put your implant in under the muscle. If we think of a little girl on a swing, so as she swings, if the rope going to the swing is up and down, she's at a relatively low position compared to the ground. As she goes forward, the swing goes higher off the ground. So if we think about that principle as we move anteriorly or forward, how the swing goes to a position higher above the ground, it's the same way with the nipple areolar complex. If we're lifting or augmenting that breast gland, it will go to a slightly higher position and therefore get some automastopexy or automatic lifting. If we move the muscle forward and the breast gland, you won't get as much of an upward transgression or upward mobilization of the nipple areolar complex. Also, if a woman has some ptosis, a little bit of droopy skin, or a low nipple areolar complex, if the implant is at a certain point on the chest underneath the muscle and the nipple areolar complex is lower than that, that will be a less attractive breast. Sometimes that can lead to a double bubble phenomena. There are many different ways to get the double bubble phenomena. But in general, we want your implant to be at a position to bring the nipple areolar complex at its maximal projecting point at about 2/3 of the way down from the top of the implant. In other words, we don't want it exactly centered over the implant. We want your projecting nipple areolar complex about 2/3 of the way down. That's been studied by plastic surgeons, and that leads to the most attractive breast, the most natural appearing breast. So we talked about the incisions. We talked about the placement above or below the muscle. Now, what about choosing silicone or saline? There are real differences. As I said, saline tends to go under the muscle. Silicone can go above or under the muscle. There's no question about the safety of saline. If a woman leaks a saline implant, she's just going to go flat in 1 or 2 days. In fact, that's what some plastic surgery offices call it. A woman gets a flat, and that means that there's a leak in the saline implant. It just gets absorbed by the body. She might pass her water, go to the bathroom a lot for a couple of days, but she'll notice that one breast is smaller than the other dramatically. If a woman has a leak in a silicone implant, she may not even know it that day. The silicone doesn't spill all over the place. It doesn't get absorbed into the bloodstream, etc. Now, if a woman does have a silicone leak, I recommend that it be changed, that implant be changed. It's not an emergency. It doesn't have to be done that day. But I certainly encourage you to see your plastic surgeon, plan it out, pick a time on your calendar when you can rest and take it easy for 3 days and 3 nights. Limited activity for another week, and then on day 11, go back to your normal activity slowly. I recommend you plan that out, but I don't recommend allowing a leaking silicone implant to just stay where it is and slowly leak the silicone. Now, it's certainly true that there's no evidence that a leaking silicone implant will cause rheumatoid arthritis or autoimmune phenomena or lupus or anything like that. However, the leaking silicone does get sponged up by the breast tissue. It can go to the lymph nodes. It's not good for the local tissue. It sets up an inflammatory process. It can lead to enlarged lymph nodes. It can make a difficult breast exam. So I recommend, if your silicone implant leaks, to remove it and change it and get a fresh new one. Now, certainly the new type of silicone implants, high cohesive gel, much different than the old silicone. Those old silicone, commonly, if we would take it out of the package in sterile in the operating room and put it on a surgical towel or surgical paper, and we'd pick it up and there'd be a little light oil film. That doesn't happen anymore. With the new silicone implants, the gel is cohesive. We can show you pictures where we take a surgical scissors or scalpel, cut right through the implant, turn it upside down, and it doesn't go anywhere. It stays where it is. And of course, there are different viscosities, different cohesive feeling, how firm the silicone gel is. And that's something that we can help you select. Silicone or saline. Saline can be placed through a smaller incision because they come empty. Saline can have the real advantage if a woman has a tight inferior pole, like if she has a constricted breast. A saline implant can lead to her advantage because it helps to stretch out that soft tissue. It's a little heavier. It stretches out the soft tissue a little more than silicone does, actually a lot more than silicone does. It's so we can use that to her advantage. Now, what about choosing your size? Implants come in almost unlimited sizes, although we cannot predict a cup size. That's a personal decision. There are different ways we can help you choose your size, different methods. I use the biodimensional approach. I like to encourage a woman to balance out her silhouette. We take some pretty sophisticated measurements of the breasts and the chest wall, and we take her measurements, the waist, the widest part of her hips, her bust size, and we can give you different recommendations. In general, for saline implants, we can offer you a small, medium, or large augmentation. For silicone, we can offer you small, medium, large, and extra large augmentation. And again, it's a custom designed approach. There's lots of different sizes available, but it's a personal decision. I think choosing a size is a personal decision for a woman. I think choosing between saline and silicone is a personal decision. Saline are less expensive. Saline tend to leak more. Silicone are more durable. But of course, silicone tends to feel more like natural flesh. The edge of a saline implant kind of feels like a water balloon, especially in the lower outer pole. There's a little crinkling feeling. It doesn't bother all women. It bothers some women. Silicone tends to feel more like flesh. We used to tell women that capsular contracture occurs more often with silicone implants. That's when the normal scar tissue around an implant will start to get thick and heavy and tighten and contract. I'm not sure that that's true anymore. It may be true, but there are other ways we can minimize your chance of getting a capsular contracture. Where we put the implant, the type of implant, how it's inserted, antibiotics, proper hemostasis, washing out with antiseptic solution, etc. Finally, very briefly, there are smooth implants, there are textured implants. In general, I don't use textured implants anymore. They used to be sold as a way to minimize or lessen a woman's chance of capsular contracture. I don't think that's true anymore, and some textured implants can set up an inflammatory process that can degenerate. We certainly don't want to do that. There can be teardrop-shaped implants. Those tend to be more cohesive or firmer, the sort of gummy bear implants. I tend to use a lot of round silicone implants. I think in the upright position it's hard to tell the difference. I think they're a natural look and a natural feel. So those are some of the decisions to be made when planning out your breast augmentation. And there are many of them, and I can help you to make those decisions, but there are two personal decisions for you to make. The choice between saline and silicone, and what size you desire to be. If you'd like any more information on breast implants, breast augmentation, or any other topic in plastic surgery, I hope you'll call my office, 831-646-8661, or go to my website, drmorwood.com, drmorwood, right here in beautiful Monterey, California. This is the Doctor is in Television program. Thank you, David. Thank you, Michael, in the control booth. I hope you'll join me another time. Thanks very much for viewing.